We'll move on to the next session. This is a SOBI-sponsored session on advancing myelofibrosis care from disease burden to real-world case insights. I will start by introducing my colleague, Dr. Omar Albanyan. He's section head of chronic leukemia, myeloproliferative neoplasm, and consultant of hematology and stem cell transplant, King Faisal Specialist Hospital and Research Center. Welcome, Dr. Omar.
Assalamu alaikum. Thank you very much, Dr. Ayman, for a nice introduction, and thank you for the SSBMT to invite us to have this talk, and SOBI for sponsoring this presentation. So I'll be talking myelofibrosis management, addressing patients' unmet needs. Philadelphia negative myeloproliferative neoplasm are a very rare disorder characterized by clonal proliferation of myeloid stem cells. Our focus today will be myelofibrosis. It can be either a de novo primary myelofibrosis or post-ETPV or a secondary myelofibrosis, and typically diagnosed with profound constitutional symptoms that affect patient quality and life. Although all cases of MPN have a risk of progressing to acute leukemia, for instance, ET and PV had a 15 years risk of progressing to acute leukemia around 2 to 5%. When talking about myelofibrosis, have a higher risk of approximately 10 to 20% of progressing to acute leukemia. So as I said, it's a very rare disease, accounting approximately 0.2 to 0.5 cases per 100,000 person per year, as per the SEER database. It's a disease of elderly, so the median age of diagnosis is approximately 65 years old, and over 70% of the patients are over the age of 60. It's important to meticulously pay attention to the diagnostic criteria for those disease population. So they need to meet at least 3 major criteria and 1 minor criteria, being the megakaryocyte proliferation with atypia, along with grade 2 to 3 fibrosis, having the clonal mutation JAK, calreticulin, or MPL, if it is negative, to have those specific clonal markers. The minor criteria being anemia, leukocytosis, palpable-splenomegaly, leukoerythroplastic pictures, and increased LDH. Additionally, it's also very important to differentiate between pre-fibrotic myelofibrosis and ET, and that's mainly distinguished by the biopsy obtained. So the pre-fibrotic usually have less than 2 grade fibrosis. ET usually have pre-fibrotic differentiated by ET usually will have a megakaryocyte atypia, hypercellularity, and granulocytic proliferation. Additionally, it's important to exclude other causes of myelofibrosis, MDS, acute leukemia, multiple myeloma, or metastatic disease, hairy cell leukemia, can always be confusing with myelofibrosis. So what is the hallmark of myelofibrosis? It's affect the CBC, so affect the hematopoiesis, mainly through the JAK-STAT pathway. It can cause splenomegaly, mainly driven by the extramedullary hematopoiesis, and myelofibrosis symptoms that is mainly cytokine driven. It does not only carry a risk of leukemia transformation, but also carry a risk of thrombosis, approximately 34%, risk of bleeding, and does have a major impact on patient quality and overall survival. What is the signals involved in myelofibrosis? So we have mainly the JAK-STAT pathway. So we have the JAK1, which is mainly play a major part in inflammation, lymphopoiesis, and stem cell maintenance, which is very important as a mechanism of side effect of the treatments. JAK2 and the inflammation, hematopoiesis. The recently understandable more is the IRAK and the ACVR1, which play an important role in the inflammation, hematopoiesis, and the hepcidin transcription and the erythropoiesis. So how does the disease impact the quality of life? So mainly hematologically driven, anemia symptoms, fatigue, inactivity, or if it is cytokine-related symptoms, night sweats, B symptoms, bone pain, fatigue, weight loss, or splenomegaly causing abdominal discomfort, pushing the stomach, decreased appetite, weight loss, and so on. So cytopenia is a major component of the disease, and it's a major challenge when it comes to the treatment management. As you can see, most of the patients throughout the disease course will develop thrombocytopenia, will develop anemia. If not initially, it is as the disease progresses, the significance of cytopenia will increase. For instance, anemia, almost all patients will experience anemia throughout the disease course. 70% of the patient will develop thrombocytopenia at their disease course. How does it impact or reflect on the outcome? So it does have a major impact in the overall survival. For instance, comparing patients with a platelet of less than 50 to a platelet of more than 100, there is a significant difference in the overall survival, with the median overall survival for a patient of less than 50 approximately is 1.2 years. Similarly, with anemia, if the patient is transfusion dependent or have a hemoglobin level of less than 8, will have a major impact in the overall survival with a median OS of approximately 2.1 years. So it's not only 50, even if the platelet is less than 100, still have a major separation when it comes to the outcome and the overall survival. So cytopenia does not only impact the overall survival, but also affect the cytokine-related symptoms or myelofibrosis overall related symptoms. So patients who are thrombocytopenic, they've reported they have worse fatigue, worse early satiety, abdominal pain, and the list goes on for all the myelofibrosis-related symptoms. So it's also have a general worsening the quality of life for patients. So what are the JAK inhibitors that is currently approved? We have the most experienced agent that we are with is the ruxolitinib, that is a JAK1, JAK2 inhibitor that is approved for the intermediate and high-risk myelofibrosis with platelet count of more than 50. Major side effect we encounter with Jakafi, and it's usually a limiting factor when it comes to continuing the appropriate dose, is thrombocytopenia. Fedratinib is the second approved agent in the US FDA. It's approved for intermediate high-risk myelofibrosis with a platelet of more than 50. Major side effect is GI symptoms that led to the black box warning of chronic encephalopathy, but that's probably just due to the malnutrition from the GI symptoms. Pacritinib is approved for intermediate or high risk, will have a specific indication for a platelet of less than 50, which comes really in handy when encountering those patient population. The major side effect is GI symptoms that can be managed with antiemetics. Last and the most recent approved is the momelotinib that is approved for intermediate or high risk myelofibrosis patient with anemia. So just following the NCCN guideline, so this is mainly for a patient who are not transplant candidate and we're not intended to take them to transplant. Usually we'll take that route. So we classify them initially based on the platelet count. So if the platelet is more than 50, then you have all the agents to choose from. If the platelets are less than 50, the preferred agent is usually pacritinib. Momelotinib still can be used, however, as category B for those patient population. And ideally, beyond that point, we'll be enrolling patient in clinical trial. So just a clinical overview for pacritinib. Pacritinib is the only approved JAK inhibitor that have a specific label for thrombocytopenia. It's a multi-kinase inhibitor, but the most unique for patients with myelofibrosis is actually it spares the JAK1. Additional to that, it have a high potency against the SVR1, the IRAK1, unlike other JAK inhibitors. So how does it impact? I've showed you this slide, the mechanism of action of the disease. How does it reflect in the pacritinib? So as shown in the far left, it spares the JAK1 inhibitor. So probably it does have a factor on avoiding the suppression on the stem cell. So it provides stem cell maintenance. It is a potent JAK2 inhibitor, IRAK inhibitor, and ACVR1 inhibitor. In addition to controlling the myelofibrosis symptoms and the splenomegaly, it also is a potent hepcidin blocker, so it's allow for more erythropoiesis and increasing the hemoglobin in those patient population. It was studied into two trials. There's the PERSIST-1, PERSIST-2. So I'm going through the PERSIST-2. It's patients enrolled with myelofibrosis who have exposed to a previous line of therapy, and they did allow prior JAK1, JAK2 inhibitor. They randomized them into 1:1:1 ratio, pacritinib 400 daily or 200 BID versus best available therapy, including JAK2 inhibitor. So the way the best available therapy enrolled are, so important to note that almost 50% of the patient in the best available therapy are receiving ruxolitinib. Other agents are hydroxyurea, steroids, danazol, thalidomide. Again, very important to note that for those who received best available therapy, 93% of them received a treatment of 10 milligram or less, including some of them 5 milligram or less BID. And we all know it is a challenge with Jakafi because it's a limiting effect in treating them. And when we go to 5 milligram, it's almost placebo at this point. So how did it translate when it comes to the outcome? So they looked at the splenic volume reduction of more than 35%, and indeed pacritinib have a higher percentage, 22 versus 3%, and when looking at the more 50% or more reduction in the total symptom score, similarly pacritinib was superior, 32 versus 14%, and they added additionally the modified treatment symptom score. Additionally, so the difference is most of the other trial, they did not include tiredness, but here they did include tiredness as one of the reported outcome. And again, pacritinib was superior, 35 versus 14%. More important is the impact of the cytopenia. So patients receiving pacritinib had an improvement in the hemoglobin, 25 versus 12%. Similarly, transfusion burden reduced in those patients' population when compared to the best available therapy. So how do we define ruxolitinib failure? First, if the treatment is receiving optimum dose for a duration of 3 months and failed to achieve a response. What are the response we're looking for? More than 20% in the spleen reduction and resolution of the symptoms reported by the patient for more than 20% when looking at the score. Intolerance is probably the most of the patient we encounter is that we'll have an acceptable side effect, toxicity, cytopenia, for which we are unable to give them the optimum dose, or loss of response. Those patients will achieve response, but later on they will have the loss of response to what is defined in the primary refractory. So when looking only on pacritinib versus Jakafi in the PERSIST trial, we still see there is significant improvement both in the splenic volume reduction, 22 versus 3%, and in the modified symptom score, 35 versus 19%, favoring the pacritinib. And again, probably because those who receive ruxolitinib, due to the challenges, they are unable to receive the maximum tolerated dose or the appropriate dose. Most of them receiving a small dose that some of the experts even call it as a placebo dose. So what are the side effect profile? It's fairly very well tolerable disease. The most of the side effects are GI, diarrhea being the most of it. However, it's manageable with antidiarrheal medication. It has a median time of onset of 1 to 2 weeks and usually resolved after a couple of weeks of exposure. Any adverse event reported is 94 versus 93%. Fatal event was 8% versus 11%. It's important to note that here they reported more cardiac adverse event in the pacritinib compared to the ruxolitinib. However, most of those cardiac events were related to peripheral edema. So going into a more understanding of the other mechanism of actions in pacritinib is mainly the ASVR1. So pacritinib and momelotinib are the two unique medication in the armamentarium for myelofibrosis that involve the ACVR, and it does have impact for anemia. When looking at the Cmax, you can see that the pacritinib have a higher level of concentration or higher potency compared to momelotinib when it comes to the ACVR and impact on the anemia. So in conclusion, pacritinib is a JAK1 sparing molecule which addresses the unmet need for a thrombocytopenic patient. It does have a higher potency for inhibition of the ACVR against the other agents. Pacritinib is associated with increase in the red blood cell transfusion independency, and pacritinib inhibition of ACVR provide strong rationale for its clinical benefit in patients with myelofibrosis who are anemic. Additional studies are needed to further elucidate the mechanism underlying benefit of the inhibition role in the IRAK and the ACVR1 inhibitor. And with that, I would like to thank you and end my presentation.
Thank you, Dr. Omar, so much. Any questions, please? Okay, if we don't we have a question, Dr. Oscar? Okay.
Omar, very nice talk. Question, does JAK2 inhibitors have a role in splenectomized myelofibrosis?
The answer is yes. Spleen is one of the targets for JAK2 inhibitor. But however, JAK2 inhibitor also impact the symptoms. So splenomegaly is mainly driven by the cytokine impact, but also can be a potential extramedullary hematopoiesis site. So removing the spleen, there is still the cytokine impact of the disease everywhere else. So bone pain, impact on the leukocytosis and the fatigue and the night sweats. So the answer is yes. I understand the question because the spleen is usually the major impact, the major barrier, and the major encountered problem with the patient.
Thank you.
Thank you very much.